Hi, everyone, and welcome. I am Dr. Nika Salim, and I'm a person living with migraine disease, and I'm also a patient advocate. I have been involved with Mouse for Migraine for a few years now as our community group leader, support group leader, and I'm more recently became a project manager on our chapter expansion outreach. As we're celebrating Black History this month, we are very excited to have all of you join us for this very important discussion on migraine and headache and how it affects the Black or African American community. You may not realize that migraine is a misunderstood and misdiagnosed disease for many people, but especially within the Black community due to racism and mistreatment that we faced throughout history. That is why we are happy to have this conversation today about what migraine is and how to get diagnosed. I'm joined today by two patient advocates and a physician who specializes in headache and migraine medicine. So I would first like to introduce you all to Grace Chappell, who is a new member of our community. Grace lives with hemiplegic migraine and chronic daily migraine. Hi, Grace, and thank you so much for joining us today.
Hey, Nika. How you doing? Hi, everyone.
Hi, I'm great, thank you. So Grace, would you tell us your story about your migraine diagnosis and how you first got diagnosed?
I started having my headaches in 2015, but I never went to the doctors in regard to my head pain because I felt like work was my priority. And I didn't want to take off any days. And we know when you're working and you're trying to take off days, it's kind of hard at times. So these headaches became unbearable and it started to interfere with my personal life and my family life. So I decided to go to the doctors to see about these the head pains that I was having. And I was diagnosed in 2017 with chronic migraine disease, which I suffer from daily. And then in 2021, of January of 2021, I was diagnosed with a mini stroke. I went to the emergency room, which they thought it was a mini stroke. I say 2 months later, I did some outpatient testing and everything. And my neurologist told me that it wasn't a stroke. It was actually a rare form of migraine disease, which were called hemiplegic migraines, that affects the left side of my body, making me paralyzed and affecting my speech, which I have attacks 3 or more times per month with these hemiplegic attacks.
Wow. First, just thank you for sharing that. It takes a lot of courage to just come out and share your story, especially on a platform like this. And a lot of what you said, I can even relate to myself being a person who lives with migraine disease, chronic daily, similar symptoms like what you shared, but also a person who works and not wanting to, share those things or take time off work or be seen as the person who's always out of work. Those are things many of us resonate with, and probably some of you who are listening, you may resonate with that, and you may be hearing things that were shared just now that kind of get your wheels going, like, hey, that might be something I'm experiencing. And that's the purpose of this program, to share those stories and for people to recognize the different symptoms and how it affects daily living. So Grace, tell us, why did you join the Miles for Migraine support group?
I actually joined because I saw the segment on Fox 29 that was called Desperate for Relief, Healing for Headaches. And I saw people that were related to what I was going through. I saw some people that actually not just related of what I was going through, they actually look like me. So that was a major reason why that I actually joined the support group, because it was more familiar and knowing that someone of color actually dealing with the same thing that I'm dealing with. Yes.
And that's why it's so important, to share our stories so that we see that we're not alone. That's a big phrase you use within our community, and I'm sure in other communities, that you are not alone. And it can feel like you're the only one going through this, but that's why our stories is so important. I do want to let you all know that please, as you're listening to this conversation, if you have questions or you want to know more information, please put your questions in the comments, in the chat, and we would love to be able to take this time to address your questions. Thank you so much, Grace, for sharing your story. I want to, if you have other thoughts to share later, please bring them back. Thank you so much.
Thanks for having me.
Thank you. Now I'd like to introduce you all to Deborah Turk. She is an advocate living with intractable chronic migraine. Deborah has held employment in the fields of nonprofit human services and behavioral health. However, due to the increasing debilitation from migraine disease, Deborah was forced to leave her career that she loved. She is dedicated to fighting migraine stigma and very passionate about the empowerment of people of color through education and self-advocacy. Thanks so much for joining us today, Deborah. So I'd like to start off with a question for you, Deb. How did you learn about migraine following your diagnosis? Oh, you're muted, Deb.
Okay. I was diagnosed with migraine, but I didn't know anything about it for many years. After I became chronic, the neurologist I had was prescribing me medication in a manner that I had a feeling was wrong. And his manner was brusque. I felt like I was a throwaway patient, and I didn't want to remain in a position of ignorance. So as I not only was suffering because I was getting worse, so I just sat down one day and typed migraine into my browser. There were migraine websites, migraine groups and blogs, and I read and I learned as much as I could.
Wow. Yeah, that's, again, similar story. I didn't put migraine into a browser, but I put it into social media because I knew I was like, there has to be people out there talking about this. And that's how I learned more about the disease after I was diagnosed, just searching. So how did what you learned help you feel empowered and lead you to become an advocate?
Well, I definitely started to better understand what was going on in my body. I learned about treatment options, and this enabled me to take an active role in my treatment instead of just going to appointments, getting prescriptions refilled and leaving. I now knew what questions to ask, and I could be confident about presenting ideas and honest if I didn't agree with something. Education about your disease makes you a partner in your care. I didn't know what I could do, but I wanted to help out the cause. So I found Mouth for Migraine and I volunteered with them. I can't put into words how satisfying that was. As time went on, I took note of the prevailing attitudes and erroneous beliefs about migraine and the people who live with it and how harmful they were. And I made it my mission to spread awareness. I shared what I learned and I began to share what I experienced very publicly. I like going out and meeting people who need proper treatment but never got it and talking to them. I love being able to tell them things they never knew. They give them hope. It's a good feeling to watch someone go from feeling isolated without hope to feeling understood, validated, and properly treated.
Wow, thanks, Deb. So you used words like throwaway patient, you use partnership, you use these kinds of words, having choices and options. So when you think about all of that in your experience and your purpose in advocacy, tell us about the disparities in migraine and why Blacks are conditioned to not ask for help, how the community lacks access, and why we think we're supposed to push through. And I use those in quotes, push through.
Right. Well, that's a subject that has some layers to it, but briefly, there are disparities in healthcare among the ethnicities as a whole, and the same is applicable for migraine. The lower the socioeconomic class, the wider the disparities become. Black Americans are less likely than their white counterparts to get properly diagnosed and receive proper treatment. Do they have health insurance? What kind? Because that matters. Do they have access to a headache specialist? Did they even get a referral? We're less likely to get a referral. Practitioners have real beliefs that genetically our pain is rosier and easier to handle. That one's been passed down since the days of slavery, enslavement. And in enslavement, everyone was made to work through their pain. Keep your mouth shut and keep moving. After slavery, you're lucky to have this job. Keep your head down, mouth shut, and keep working. We've been conditioned for hundreds of years to bear pain in silence or pay steep consequences. there's a term called medical mistrust, and it sums up how many in the Black community feel that there is an absence of confidence that the medical community has our best interest at heart. For centuries, we've been treated like guinea pigs without anesthesia by so-called doctors and scientists. Many hospitals only integrated because they were forced to. That didn't change the mentalities of those inside. This is a multi-generational trauma. And this is what many well-meaning non-Black people don't get. Traumatized people hear differently and communicate differently. You got to work through those layers and establish trust. If we don't trust you, we're not going to take risks and follow your lead, and that will lead to poor health.
Wow. Wow. Those are deep words, and thank you so much for sharing your story, your experiences, and why this conversation is so important. So we've spoken to two patients. We've seen and heard the patient perspective. So now we're very grateful to have someone here that can share the physician perspective. And I'm happy to introduce to you all Dr. Larry Charleston IV. Dr. Charleston is the director of the Headache, Facial Pain Division, Director of Faculty Development and Professor of Neurology in Michigan State University, Human College of Medicine Department of Neurology and Ophthalmology, and an adjunct faculty at the Jefferson Headache Center. Wow, that was a lot. I hope I did not miss any of that. Thank you so much, Dr. Charleston, for joining us tonight for this discussion.
Thank you, and you did a fantastic job. And I want to just start off by saying thank you to Mrs. Turk, Mrs. Chappell, Dr. Salim, and also Miles from Migraine for having this, Shirley Cassell, Derek for helping us, kind of these people in the background for making this thing, making this panel and this discussion possible, and hopefully reaching a lot of people that we don't really, that may be feel like that Mrs. Turk said that are overlooked, or Chappell said that feel like they've been thrown away. So I really appreciate the opportunity to talk and appreciate this panel.
We're so glad that you're on. And I think one of the key points here is to, like you said, reach those people who we may not reach. And so with that, I want to encourage everyone to please share this. Invite others who may not be on to come on and engage in this dialogue. But I think that you should be able to share it afterwards. So this is very critical for our community and those who may not even recognize they're living with this condition. So with that, Dr. Charleston, would you just explain to us what is migraine, and can you talk about how to identify migraine?
Yeah, absolutely. So migraine is a headache disorder. It's it really is a brain disease. It's characterized by different phases. A lot of people think of the headache phase or the severe headache as the migraine, but headache is really just one of the phases. There's a prodrome or premonitory phase that is associated with symptoms. It could be problems concentrating, or irritability, or yawning, or cravings, or difficulty speaking or reading, nausea. It can be aura phase. So for instance, the hemiplegic migraine is actually an aura. So about a quarter of patients with migraine disorder have aura. So it's usually 20 to 30%, depends on where we read in the literature. Most common are visual disturbances, but you can have other, and when I say aura, what I mean is a really reversible neurological symptom, right? And it usually lasts from 5 to 60 minutes, usually. Then there's the headache phase of migraine that a lot of people know. It can be 60% of people have it on one side only. 40% of people have it on both sides. So it's known as this one-sided headache, but not always. It's characterized by throbbing, and it can be burning. It can be sharp. It can be associated with nausea or vomiting, sensitivity to light, to sound, and sometimes smells as well. And then there's the postdromal phase that can occur about for 24 to 48 hours. And that could be some of this, where I hear it a lot with my patients, like this brain fog, right? So difficulties to concentrate, mood disturbances, whether depressed or euphoric mood, and different fatigue associated with it. And so it's the migraine is the second most disabling disorder and neurological disorder in the world. I mean, this is not a small problem. And sometimes patients come and I say that they're like, well, what's going on? What's going on? I'm like, it's very prevalent, and I think that we need to do a better job, really, in the healthcare, of educating our providers about migraine. It's very prevalent, and depends on where you read. Let's say approximately 40 million Americans have migraine. So somewhere right around 40 million Americans has migraine. Not everybody has the chronic daily type, thank God, right? But not everybody has the chronic daily type. But it is a spectrum. So the disorder itself is a spectrum. The frequency itself is a spectrum. Its impact on people is a spectrum, but it is the second most disabling neurological disorder.
Wow, 40 million people. It's a lot of people. Second most disabling neurologic condition worldwide. I mean, that just helps to really bring light into this hidden and invisible condition. So there is apparently over 300 classifications of headache. Can you talk a little bit more about that?
Yes, absolutely. So, and I said migraine, and I tell people, again, by the way, I say migraine, and I do this training even just yesterday with a family medicine resident that was training with me. I had a neurology in the morning, family medicine in the afternoon. I'd say primary medicine is so key, because that's the first contact that people have with getting care oftentimes. So there are over 300 different headache disorders, and this is divided basically into three categories. And we get this classification from what's called the International Classification of Headache Disorders. And they're divided into primary headaches. So migraine is a primary headache. Secondary headache, so you can think of a post-traumatic headache as a secondary headache. And one of the things that some patients will go up and down with me is like, why am I seeing a headache specialist? I have facial pain, or I have trigeminal neuralgia or something like that. And I have to tell them this is actually included in headache medicine. So there's a section or category of neuropathies, facial pains, and other headaches. And so there's a lot in with headache medicine. Diagnosis, right, is really key. History is key. It's actually one of the reasons why I actually got into headache medicine personally, because I recognize if we can get the diagnosis right, and some people, we can treat them right. Every headache is not the same, and I think that's really important. I was wild when I learned that there was 300 different headache disorders, and I didn't learn that until I was into my neurology residency. So again, I'm grateful for a platform like this where I can actually share that. So not every headache or headache disorder is the same. And so that's why history is really, really important.
Yep, you and Deb both touched on the history, and I think that that's so critical. Would you talk a little bit more in your profession and your experience as a headache specialist, or just in general? What are some of the barriers that you think African Americans or Blacks face versus whites?
Yeah, I agree so much with Deb, Ms. Turk, what she said, that there are barriers in migraine in general, right? I mean, and what happens, I think that there's we use this term in diversity, equity, inclusion, the intersectionality, or that there's intersection. So let me talk about a couple of barriers. So there's studies that demonstrate barriers in effective migraine management being male sex, just being male. When I talked about the differences, I mean, or the number, the prevalence, it's about 2 to 3 women to 1 man, or what have you, as far as kind of the epidemiology, the prevalence of migraine. And so sometimes being a man itself, although I know we have ladies here, but being a man is a barrier. Lack of health insurance, appropriate medical consultation, failure to receive an accurate diagnosis. And speaking of diagnoses, there is a way that I think that people can be empowered. It's called with a migraine diagnosis, because you can either rule it in or rule it out. It's really good for ruling out, and it's called ID migraine. And the reason why I bring this up, because it's essentially three simple questions. And I think of my colleague and really fantastic educator and physician, Dr. David Dodick, where he said, you got to pin the diagnosis. So what is PIN, right? So what is this ID migraine, which is a trademark, right? It's a 3-question questionnaire trademark. So PIN stands for photophobia. What does that mean? Sensitivity to light. So photo, like photographs, a phobia, fear of, right? And so I don't want to get too technical, but pretty much everybody can understand that. So does light bother you when you have a headache? Like over the last 3 months, you had a headache, does light bother you? So that's the P in the PIN, right? Has the headache limited your activities, like work, school, or something that you need to get done? And that's because it's so intense, right? So that's the I. So we got the P and the I. And do you feel nauseated or sick to your stomach when you have headache? That's the N for nausea, right? So we pin the diagnosis. And just those 3 questions, I mean, if people don't have that 3 questions, they can still have headache, but it's a great possibility that you rule out migraine. But if you have 2 or more of those questions, then it's possible that you do have a migraine. So getting an accurate diagnosis is a barrier. And this is just for people with migraine. Not being offered minimal evidence-based pharmacological or behavioral regimen, appropriate education to healthcare providers. I was saying that a little bit earlier. And then there may be more barriers that exist for patients who have chronic migraine in contrast to episodic migraine. And we hear that from the panelists today, including appropriate headache consultation, appropriate acute and pharmacological treatments, medication overuse, headache. People don't like that diagnosis. I think it should be substance-induced adaptive headache, but that's another topic. But and then we talked about the accurate diagnosis there. There was one thing, because these are just that's in general. Now let's talk about African Americans, right? I mean, there's also the social economics. I don't equate social economics to African Americans, although, as been pointed out, there's been challenges for achieving certain status for some African Americans, right, with a lot of practices and policies that have been enforced or implemented or in the United States. Okay, so so there are things. So social economic status is across the board, whether you're Black, white, Asian, Puerto Rican, whatever. But there's some with African Americans and people of color. And that may be based on unconscious or implicit biases. And this may be manifest in the fact that the pain is not maybe taken as seriously in African Americans. In fact, there's a systematic review that demonstrates that most healthcare providers appear to have implicit biases, right? So these are things that we don't think, these are biases that we don't necessarily think about, but we've been essentially conditioned to based on our society, but have implicit biases in terms of positive attitude towards non-Latinx whites and negative attitudes toward peoples of color. And this is significantly related to patient-provider interactions, treatment decisions, treatment adherence, and the fact, because someone mentioned invisible disease, the fact that the absence of objective measures in pain and medical judgment can have pain more vulnerable to physician or provider biases. Okay, and we do know, and I say that we do know that even in cardiovascular risk, like there's implicit biases of that resulted in a decrease in perception of cardiovascular risk and fewer referrals after racial priming of patients with chest pain. And these are observed in more time pressure situations, right? So if there's a lot of time, if you have a lot of time, you have less of these biases, but if this time is short, then you see these biases seem to come out. And as was said earlier, there's white lay people, even medical students and residents hold false beliefs about biological differences between Blacks and whites. And I'm not talking about this was published in 1990. I'm not even talking about this was published in 2000. This was published about for 6 years, 5-6 years ago. Okay, and so these beliefs predicts racial bias and pain perception and treatment. And so I'll state there's more, and reason there's more here, but I didn't, for the sake of time, I will kind of conclude. And the reason why I stated that there may be additional barriers, or these may be additional barriers, is because there's not many studies that examine unconscious biases, particularly with race and ethnicity, specifically in headache medicine. And I will say that I really do believe that we are all part of one race. Okay, that's my belief, that science will back that up too, that we're all part of the human race. But we live in a race conscious society where people of color and indigenous people have been badly treated and been discriminated, that we have this term when we all say race, people understand what that means. And so I think we have different ethnicities, but so I'll stop there. So these biases, unconscious biases, may be some things that may facilitate some of these barriers that are experienced in African Americans that whites may not experience.
Yeah, and so we have some questions coming in, and I want to make sure we're getting to those questions. But if you can tell us very briefly, I think this is a critical point that you brought out. With all of these biases and with all of the stigma, and as you mentioned, hypertension, like hypertension, diabetes, we know these are prominent within our community, and there's a priority placed on those conditions. How do we encourage and strengthen our community to prioritize this healthcare, their healthcare, and identifying and dealing with this disease, versus, like Deb said, we're conditioned to push through, versus just saying, I'll deal with the headaches, I'll deal with that pain, these other conditions are more important. How do we move our community towards overall healthcare and including migraine and headache? If you can answer that.
Yeah, no, that's a great question. I think that this mistrust that was stated earlier, I think that's huge. So I don't think the burden is only on the African American community, right? In general, I think that this is a whole system wide, so we all have to understand. Literature does suggest that there's a decrease in quality of life. So we're looking at that, and that there is increase in depressive symptoms and severity, chronicity, and frequency, and mistrust, and even allodynia, which is a sensitive, or should I say, it's a non-painful stimuli that's stimuli. So it becomes painful, that we see in migraine. So I think that we have to understand the impact. If we can start to understand, because I'm not taking away from any other this disease or anything like that. We need to be healthy, period, as a community, period, okay? And there's more than one thing, though, right? A lot of times that we're dealing with and that we're facing. So if we can start to kind of look at or understand the impact that the significant burden that this has, I haven't even touched like economic burdens and all this type of things like that. And it is invisible, right? And it's one of those things, like you mentioned hypertension. Hypertension is one of those things that's kind of invisible until it's too late, right? Or something happens, right? So we've been more alerted to that, and as we should be. I mean, I absolutely think we should be. But we need to be more alerted to headache medicine. I mean, everybody has a tension type. I mean, a lot of people have tension type, not everybody, but a lot of people, 92% is really what this type has, like a tension type headache, and you take some over the counter, all right. But not every headache is the same. And so if we can stop thinking that every particular headache is the same, that's what we talked about, this 300 different headache types. Then we can start to understand, right? Is there a role for healthcare management? Should I go see a healthcare provider? Hey, it's not all in my head. Hey, this is affecting a lot of people. It's not and this is affecting our family. This is affecting me spending time with my children or my parents or my cousins or social events, whatever. That gets to quality of life. So we can understand that impact, right, of quality of life, not only the African-American community, but also the other institutions and the headache and the systems, healthcare systems and things like that. I think that's good. And I don't want to take away from anything. Everything are diabetes and high blood pressure and all these things they're very important, but headache is important as well.
Right. So we thank you so much for sharing the physician perspective, Dr. Charleston and Deborah and Grace for sharing your perspectives as patients and advocates. We do have a few questions and we're running low on time, but I do want to try to get to a few of these questions. And from the way they're asked, it sounds like these would be for you, Dr. Charleston, but I want to encourage anyone else who may have a different perspective to share. The first question is, why is it, we talked about these 300 different headache types and different types of migraine. Why is it so difficult to diagnose the type of headache that a person has?
So that's a very interesting question. I appreciate the question. I don't know if the term is difficult. I think it's difficult when you don't know it exists, right? So, and that gets to healthcare providers, right? If you don't understand, and in medical school, there's studies that say that there's only a couple of hours that's spent on headache disorders. So you have the second most disabled, and that's just taking the migraine, right? We're not talking about the other 299 headache disorders, okay? Right? We're talking only about migraine. And as a medical school, in most medical schools, you go through 4 years and your average treatment is like 2 hours on this whole thing. So that's why it becomes difficult to diagnose, because people don't understand. We don't know what the diagnoses are. We don't even know to think about the diagnosis. There are areas in medicine that just because I'm just not part of, I don't know to think of it. I don't even know that diagnosis exists. And so that's, I think, where some of the challenges are. And so we really want to work again. And the American Headache Society is actually they have what's called First Contact, where it's actually working with primary care physicians so that he can have a better understanding of different diagnoses. So it's always good to know when to diagnose, when you can diagnose something, right? And when something is a diagnosis, but you also need to know when it's not something too, right? When it's something else, and we need to maybe further up the management, or, hey, I just don't know what's going on. And we call a friend, right? We ask help, we talk to a colleague or something like that. So, but we have to know, sometimes we don't know what we don't know sometimes.
Mm-hmm.
Right?
So for all of you out there who are watching, who may be looking for a path in medicine or determining where you want to spend your residency, consider migraine and headache medicine. The next question, are there comorbid conditions with migraine? And I think this would also be for you, Dr. Charleston, and anyone else who may be experiencing comorbidities.
Yeah, I don't know if someone want to answer. I mean, quickly, yes, there are a lot of comorbidities. I mean, we see comorbidities. We see it with sleep disorders. We even see some Parkinson-like comorbidities. We see epilepsy. We see mental health comorbidities. We see what else? In GI comorbidity, like irritable bowel syndrome. So yes, there are a lot of different comorbidities that are associated with migraine per se. Mm-hmm.
And just to explain terminology, can you just share for those who may not know what comorbid means?
So the way that I describe it, and the way that I describe it to patients, hopefully is great on this platform. So you have one disorder that goes along with another disorder. It's like they ride in the same car, right? But this happened more than coincidence. So it's not just a coincidence that you have it. It's just one disorder riding with another disorder in the same car. And I tell patients sometimes, as we treat the headache disorder, some of the other comorbidities, right, will get out the car. Sometimes we have to be a little bit more directed in the treatment of those comorbidities. So hopefully that helps kind of explain. These are two different disorders that kind of just, they roll together.
Yeah, thank you. All right, last question. We only have time for one more question. And I think this is a question all of us have asked, even upon getting this diagnosis. Is it curable?
I'm not aware of any cure, okay? And I think what I would love that there be a cure. I tell patients all the time too, that I don't have a magic wand. If I did, I'll be on a yacht somewhere, somebody else be using it and everything like that, because there's a lot of people that could use it, right? But I think what we want to make sure, I mean, while we don't have a cure, I think being able to manage, right? Being empowered to manage the headache disorder, being empowered to live life, right? I think that's what we really want to strive to, right? We don't want this, just like there's not necessarily a cure for some other chronic disorder, right? So there's this chronic episodic disorder, right? Or chronic disorder, right? So like hypertension, you don't necessarily have a cure for that. You know, diabetes, you know, I mean, it depends on which type and everything. But again, you get the idea. So, but how do we manage, right? So that it's not affecting our life so much. I think that's what we strive for, right? And so I don't know of any cure. And so when people say that it's a cure, you know, we be very cautious and very, very careful about that.
Thank you so much. Any final words from any of our panelists? We don't have time for more questions at this moment, but we encourage you to visit our website, Miles for Migraine. You can reach out with any questions you have, but I do want to give the panelists a moment if there's one or two final things you want to share before we wrap up. Yes, Deborah.
Yes, I'd like to say, I just want to encourage everyone who is looking for support and you know, who haven't really been or been able to speak to other people with migraine, you know, to come and join us. Miles for Migraine has support groups that we have right on Zoom, and they're very private and confidential. And many people have found them very helpful, and we definitely welcome you if you just want to go on the Miles for Migraine website and register. I'm one of the support group facilitators, so you might see me.
Thank you so much for sharing that. And that's milesformigraine.org, O-R-G. And you can find not only the community support groups that Deborah just mentioned, but you'll find information on our education days if you want to gain more awareness for either yourself or someone you care about, a loved one or friend. We have patient education days. We have race events, walk, run, relax events where we fundraise to get more research, to spread awareness about this condition. You'll find information there, or if you just want to submit a question, you can share questions there. And we have the new advocacy training program. There's so much going on in this community. So like we shared, you are not alone in this walk. If you have migraine yourself, or you know someone who lives with migraine, you can find resources for how to support someone or how to continue living with this disease. With that, anyone else before we close? Okay, with that,
thank you all for joining. That's all. That's all.
Yes.
I just want to express my thanks. Thanks for you. Great job moderating and leading us and guiding us. And again, behind the scenes, I know there's Derek and Shirley behind the scenes, our panelists here, and everybody that's watching. Again, spread it and share it. And I just want to express a lot of things. And I want people to leave with a sense of hope. I do want people to leave with a sense of hope. So thank you for having me.
And thank you to all of our panelists, Dr. Charleston, Deborah Turk, and Grace Chappell. And we thank you all so much for joining us tonight. Share this and be well. Thank you so much. Bye.